Good morning. Welcome to House Appropriations. It is February 5th, and it's 9 a.m. or 10 a.m. And we are here to listen to testimony from the Department of Mental Health. So, welcome.
Thank you. For the record, Emily Hawes, Commissioner for the Department of Mental Health.
Samantha Sweet, Deputy Commissioner for the Department of Mental Health.
Good morning. I'm Shannon Thompson, the Financial Director for the Department of Mental Health.
Great. So how would you like to proceed?
Sure. We're going to go over a quick overview of the mission and vision of the Department of Mental Health, a brief summary of the services we provide. We will go into our new initiatives, and then we'll end with our ups and downs.
Okay, great. Go ahead. Thank you.
Yeah. So the Department of Mental Health, our mission is to promote and improve the mental health of Vermont. And as you can see from this slide, that is quite a comprehensive approach to supporting our community members. So in 2019, 2020, the department works across the state to develop Vision 2030. And we continue to work towards the action areas that were identified in Vision 2030. And that is what you see up here on the screen. Okay. If you remember our BAA testimony, the department is responsible for oversight and designation of 10 designated agencies, 2 specialized service agencies, 6 designated hospitals. We operate the Vermont Psychiatric Care Hospital, which is a 25-bed hospital located here in Berlin for adults. We also operate River Valley Therapeutic Community Residence, which is a 16-bed residence in Essex. As a whole, we have around 233 staff working across our 2 facilities and around 69, 70 central office staff. Those staff support all of the administrative work, like our business office, legal services, our quality management teams, operations, research and statistics. All of those are operated outside of or within our central office, leaving the direct care to the 2 facilities. We collaborate closely with local hospitals. We also have a contract for forensic psychiatry. We do psychiatric consultation with primary care focused on pediatrics. And then we also work closely with our Vermont care partners, the Vermont Federation of Families and Children's Mental Health, the Center for Health and Learning, and so on. From a mental health system perspective, we, at the community level, we operate adult crisis beds, youth crisis beds, and then we have the adult intensive residential system. From a hospital level of care, which is our highest levels of care, we have our level 1 involuntary. That is a mixture of beds at the Vermont Psychiatric Care Hospital, Brattleboro Retreat, and Rutland Regional. We also have non-level 1s for folks who are involuntary and voluntary. There's 128 beds across our system for that level of care. And the difference between those 2 is essentially the amount of resources that somebody may need in order to achieve the most appropriate care that they need in that setting.
Can you, for the layperson in me, can you tell me what level 1
Yeah.
is?
So level 1 is our most acute hospital bed. And
This be likened to a nursing home if
nope, it's in a hospital. Yep.
Okay.
Hospital level. It's how the state of Vermont defined the replacement beds of the Vermont State Hospital after Tropical Storm Irene washed away those beds. And so the state of went to a decentralized hospital system for the level of patient that used to access the Vermont State Hospital. And so those level 1 beds that's essentially your state hospital beds. Yeah. We also work with our peer service agencies. We have 2 crisis beds for adults in our peer services, as well as 5 intensive residential. And then the department oversees and operates the River Valley Therapeutic Residence, which is a state-run secure residential in Essex. Going to transition us into new initiatives. So the Department of Mental Health has 2 new initiatives, which are building on previous initiatives from previous legislative sessions. This first initiative, referred to as CCBHCs, otherwise known as Certified Community-Based Integrated Health Centers. That's a long one to remember, so I apologize. I stumble on it every time. So what our is with the CCBHC model, which is a national model, is to ensure access to our community members for evidence-based substance use disorder treatment, mental health services, crisis response 24/7, as well as access to medication-assisted treatment. Medication-assisted treatment is individuals who have a primary opioid use disorder, so treatment, medication treatment for individuals with that, and alcohol use disorder. The CCBHC model requires agencies to meet a robust criteria regarding timeline of access, quality reporting, staffing, coordinating with local services and education systems.
Yeah. Representative Blumer.
When you say timeline of service, are you talking about just hours
Access.
that are open?
Hours that are open, access to calling, getting an appointment and being seen, and then also coordinating across healthcare systems. It also includes increased access for vets, includes peer services or services by persons with lived experience. And there's a flexible funding approach to the CCBHC model.
Sorry, what does that mean, a flexible funding approach?
Yeah. A flexible funding approach allows us to develop a rate directly with the agencies. And it's essentially a cost per service rate. Right now, the state of Vermont has been chosen to be a demonstration state for CCBHCs. And what that means is while we're in that demonstration, we have access to an enhanced federal drawdown for those services delivered within the CCBHC model.
I'll ask.
Just, yeah, hold on one second. Just as an FYI, Representative LaRoche is joining us online. And Wayne, I just asked you, I am trying to keep an eye on the hand raise on this little monitor here, but I may miss you. So if you feel ignored, when we're doing screen sharing, we can't see you. So feel free to speak up. Representative.
I can hear you. I'll just speak up if I raise my hand. Thanks.
That makes my job easier.
So, and I know this is just I'm just asking for, 15,000 foot understanding of, the new federal models. I know there's other federal models that are moving away from fee for service.
Yep.
I've been hearing a lot about our work here in different fields as being fee for service rather than services available globally at any time. So can you explain why why this program might be fee for service as opposed to just the larger model that matches
Sure.
the other head or whatever it is
Yeah.
that we're hearing about?
This model is actually complementary of a head. It is not a fee for service model. This is, in our demonstration, it's a daily rate. So it is not a, per hit, per service reimbursement model. And that is part of the flexible funding that a CCBHC offers.
Yeah, that's enough for now. Thank you.
Okay, yeah. So the Department of Mental Health engaged in CCBHC activities back in 2021, where we had a planning grant. Since that planning grant, we have gone through the process of applying to be a demonstration state, which I indicated earlier. And with that demonstration state status, we went through an RFP process and chose 2 agencies to begin the certification process. And those 2 agencies are the Claire Martin Center and Rutland Mental Health Center. Those 2 agencies will begin operating under the CCBHC model in FY20, or not, excuse me, yeah, in July 1st. The other agencies listed up here on the screen, HCRS, Howard Center, and Northeast Kingdom, are also in the works to become certified. All of these agencies were awarded planning grants themselves in order to move towards this delivery of care model. As you can see from the bottom timeline arrow, this is a building upon our evolution of the community system. And so we're continuing to integrate substance use into the mental health system and deliver those co-occurring integrated services with vets and the crisis services, including our enhanced mobile crisis, and then of course, persons with lived experience. So I'll pause there and see if there's any questions right now.
Any
Can't
questions?
see my hand. I do have a question.
Okay, yes, go ahead, Representative Flores.
Do you have any assessment of how many of your mental health cases or what portion of them are related to drugs or substance abuse as opposed to, other factors that are not related to substance abuse?
So I think yes and no. I think we have as clear of data as we're able to, which is typically based on billable services. And oftentimes when you bill a service, you need to do that with a primary diagnosis. I think that it's safe to say that from an adult perspective, most folks interacting with the mental health system also have some sort of co-occurring disorder. And when I say most folks, I would say 80–90% are also utilizing some of their substance. That could be alcohol, opioids, so on and so forth. So a large amount of our system is working with folks with co-occurring disorders.
Thank you.
Questions over here. John, did you have one? No.
Might have been mine.
Representative Giacomoni and then Representative Nyberg.
Thank you. Would it be fair of me to characterize the CCBHC initiative as intensive wraparound services?
No, not necessarily. The CCBHC model is not necessarily driven by the intensity of someone's need. I think when we were in here for BAA, you had some questions related directly to intense family wraparound programs. The CCBHC model does not include those types of programs in there or those types of services. So most agencies will have a CCBHC rate, but there are things outside of that rate, like residential programs are outside of a CCBHC rate.
And what was behind my question, though I'm sure not very clear, I'm wondering, when someone goes to a residential program for help and they come back to the community, how do we know who the lead is on their aftercare? Who's in charge of helping them get to success or stay successful?
From a mental health perspective, that's a collaboration between the mental health. If that person is in somebody else's custody, say DCF custody, really depends on the situation for the youth and the family. If the person is engaged in mental health services at a designated agency, those designated agency staff are going to be the lead on what things that they're the content expert on. But then also help collaborate across those systems.
So someone could call a designated agency and saying, Dave's coming home next week. Will you help him?
Yeah, so if somebody is in a residential program and that's been, that youth has been placed there through the Department of Mental Health or another department, that collaboration is happening throughout their stay at residential. If it is someone who, say, has private insurance that maybe we weren't engaged with that placement, and they want to receive services at a designated agency, those referrals can be made, but that's a collaboration between the program staff at the residential. They have folks who are social workers who are in charge of discharge planning. And there are requirements when somebody steps down around engaging with community providers that those all residential resources from this lens are required to participate in.
Just one follow-up, if I may, briefly. I'll try to keep it. Thank you. You have a picture of that. Flip it around, going in. What's the process for getting into residential care?
Sure. And I'm not the full content expert, but I can give a high level. So depending on who is making that referral into residential care. So education can make referrals into residential, so can DCF. From a DMH perspective, the DMH care management team is working closely with the direct providers on the ground, as well as the educational components and the potential referral source and admission. And they're holding that case as it goes through all of the different levels of care and overseeing to make sure that those connections are being made. That also happens at the adult level for individuals coming in and out of the hospital level of care, our intensive residential levels back out into your more community-based services.
I'm sorry, Representative Nigro.
Thanks. I just asked for locations of all of these. Is Rutland Mental Health Services, is that the furthest south of these 5?
For right now, yes.
And did I see Representative Stevens? Did you have a question?
Thank you.
Okay. You were stretching your hand. I can see it.
Stretching is very important. Next, we'll move over to our second initiative, and I'll turn it over to Deputy Sweet.
Thank you. And I do have a residual cough, so I apologize ahead of time. It's super annoying to me, so I'm sure it's annoying to all of you. But alternatives to emergency departments, I'm sure you've heard it called mental health urgent care as well. And we have found that alternatives to EDs is a critical piece of what is needed in our community. We have been able to provide immediate and community-based mental health supports instead of someone having to go to the emergency department to get those crisis supports, crisis screenings. They can actually stay in their community and go to the alternative to emergency department. So this also leads us to providing timely and compassionate crisis care. We know, I'm sure many of us have been to the emergency room and have seen the wait times there and how that space isn't really therapeutic for someone going through a mental health crisis. And so we have expanded throughout Vermont to highlight how that care can happen in the community at these alternatives to ED.
And just for the clarification,
Yeah.
Going to the emergency department is probably not therapeutic. It's for not
Anyone, that's true.
I mean, it's not something we look forward to
Yeah.
doing.
It's true, that's true. And so I completely agree. And we'll focus on mental health care for this. And so what we have found is that what this has also led to is that individuals can go to alternatives to emergency departments, so the mental health urgent cares, and receive support from their community mental health agency. And they can get connected to their agency much quicker than going to the emergency room. Let's go to the next slide. So this highlights how many alternative to ED programs we have in Vermont. They're all a little bit unique. And so we have Interlude, which is in Addison County, and CSAC Counseling Services of Addison County provides that for adults only. We have Front Porch, which is in the Northeast Kingdom, and Northeast Kingdom Human Services provides that program, and that is for the whole age span. We have the Access Hub here in Washington County, and that's provided by Washington County Mental Health Services, and that is for adults only. And then we have Mental Health Urgent Care, which is in Chittenden County. That's provided by the Howard Center for adults only. We have Psychiatric Urgent Care for Kids, which you'll hear called PUC. We like our acronyms, and so that is provided by United Counseling Services in Bennington, and that's for ages 3 to 18. We have emergent psychiatric intervention for children's, which is called EPIC in Lamoille County, and that's provided by Lamoille County Mental Health Services. And that's just what it says, it's for the youth. And then we have Youth Stabilization Program provided in the Wyndham, Windsor counties, and provided by Health Center and Rehabilitation Services, HCRS, and that's for the adolescent population. And then lastly, we have in Burlington, it's called CARES program, and that's for ages 6 and above. And that's a partnership between Burlington Police Department and partnering with EMT or a nurse, and that's modeling after the CAHOOS program. What we do want to see, we have a number of different programs all throughout Vermont. What we want to see is programs serving the whole age span. So we would like to see every program serving the whole age instead of just specializing in youth or adults. So we'll get there. This was a response from an RFP to see what works in your county. What do you need in your county? Where do we need to go? And so this was our first go around with alternative TED. So we have found what works and what doesn't.
Representative Lowey and then Representative.
Thank you.
Yeah.
Thanks for this work. I just wanted to pick up the point you make about what works and where it's landed. I'm noticing the hours here are pretty much regular business hours.
Yeah.
I don't know if you have any data about when people tend to be in crisis.
We actually do, and we found that we had the same concerns of seeing this is really Monday through Friday during the business hours. And what the data is showing us that more people are going into crisis during those hours. That's when the schools are open. That's when schools are making the connection with crisis services. So surprisingly, this is the time frame of most crises. We would like it to see going into the evening, into the early hours of night. Very few go in during the overnight hours. And so that is, oh, perfect. Forgot we had this slide on here. Oh, perfect. Thank you. So Nicole just added this slide to show like what we see is most calls to 988. And so most calls are before 9 p.m. And very few go into the overnight. So we would like to see some hours expand with the alternatives PD, but I don't know if they're needed for the overnight hours. Very few go in during that. So.
So we have questions from Representative Spencer and then Representative Logan.
Thanks so much.
Yeah.
So we're starting your slide here, starting to answer a couple of questions that I had here, but just as a follow-up, Ricky here, what kind of capacity do you have across these sites? I know it's a new initiative here, so
Yep.
you're building that information and data, I'm sure.
Yeah, I was going to say, one of the challenges that we also have with expanding hours is staffing. That is a huge challenge for our designated agencies. It's a huge challenge for our facilities. It's probably hitting every sector. And so that is one of the biggest challenges to expanding the number of hours, I would say.
Thank you.
Yeah.
Senator Logan.
Yeah, I just wanted to know how, how are these funded?
Yes. So they are currently funded by a few sources. So take out mental health urgent care in Chittenden County with Howard Center, and the Northeast Kingdom Front Porch. Take those two out. The rest are currently funded through the use of HCBS FMAP dollars, which is a grant fund. And that grant funding ends at the end of March 2026. And so what you will see from our ups and downs is we have a base ask of around 800,000 and some change, which is the last quarter of 26. That gives us more opportunity to analyze what's working across our state, and develop a regional approach from a driving perspective and community need perspective, and incorporates the work we're doing with CCHCs. So there's a long-term strategy. I guess this is a more complicated answer than your question. But there is a long-term strategy related to mental health urgent cares and our CCBHC model. But currently they're funded under the HCBS FMAP dollars.
Representative Dickinson.
Yeah, according to what's on this screen on this, what I heard you say is that most of the urgent crisis care seems to happen during the Monday through Friday workday. Yet you have the 988 trends, it's 9 p.m. for the most calls received, and 7 to 10 is the peak window for calls, and Friday and Saturday are peak call, I mean, the weekends, when everything sort of falls apart.
Yeah.
People are out drinking, or they're out socializing, or they're out fighting with their spouse, or whatever the issue may be, So who covers that? I mean, I remember way back when I was on the board of the mental health agency in Franklin County. Long time ago. They had a 24/7 hotline, or someone who was there available that you could go to the hospital, or they could go and meet with people. And obviously emergencies and acting out and all of these other things happen on the weekends, and they happen at night, So where do these other pieces fit in?
So every agency still has that. NCSS still has that. It's 24-hour. All 10 designated agencies still have their hotlines. So that's still locally run. They still staff that 24/7. They can still respond to emergency rooms if that is needed. What we're trying to do is show that there is an alternative place to go. You don't have to go to emergency departments. So this is 988 data. And we know that from the 988 data, 98% of the calls that come into 988 are resolved on the phone. So they don't even need the next step.
The intervention.
Yep. And so, but what we do have now is enhanced mobile crisis. So if someone does need something more than just that 988 phone call, 988 can dispatch statewide enhanced mobile crisis. to wherever that person is. So they don't have to go to the emergency room. They have, so we're trying to create a whole system of care, a crisis system of care with 988 enhanced mobile crisis alternatives TED, which is up to 20, it can be up to 23 hours a day. And then we also have crisis beds in our system that have been in our system for quite some time. That can be more than 23 hours. Those can be, you know, 1 night to 7 nights to help someone stabilize. So did that answer your question?
Yeah, yeah.
Okay.
Just trying to,
Yeah.
I can see when the schools are open.
Yeah.
And there's things. The other question I have, and this is something that comes down to the school issue, is that when I served on a school board, we had a cluster of suicides that was really obviously very difficult.
Yeah.
But lots of other things happen that aren't that extreme within the schools. And there was a crisis management team that came over from mental health, and the guidance counselors and the teacher. There was a group that, an administrator, they worked together.
Yeah.
To try to work with both the student or the family or both, or.
Yeah.
Is that still around? I mean,
Yes.
listening to the need for the real lack of mental health counselors in the designated agencies.
Mhm.
And at the same time, you're getting more, they're hiring them more in the schools.
Mhm.
You know, the coordination was vital because this isn't just the child, this is the
Community.
family and the community, and
Yeah.
it needs all of that.
Yeah.
Is that something you're still working on, or is that part of this?
That is still I would say our designated agencies still have that system in place. They still are able to respond to community needs when there is a bus accident or a cluster of suicides or whatever it may be. Our emergency teams at the DA still respond to those.
Okay.
I haven't heard otherwise, so I'm gonna say yes,
Yeah.
they still.
And what I
respond.
would add to that is we want our emergence, it's sort of starting to evolve a little bit around that response. And so we would want, say, an enhanced mobile crisis response to go to the school versus somebody who's gonna screen for hospitalization,
Mhm.
for a psychiatric hospitalization, because our enhanced mobile crisis response is co-occurring. And so they're gonna be able to respond to the school with training in both substance use and mental health. And then if that youth needs a higher level of care, hospitalization, then we can work towards that. But our goal is really to make sure that we're responding to schools and that youth are staying in their community if that's the appropriate place for them to be. And the challenge with a system that's evolving, and we're going to get into staffing, is what happens at the same time is analyzing the staff that are providing services across the system and what skills are education requirements are very similar. And how can we more efficiently deliver that care and at the same time bill for that care? Because that's an important component to this as well. It's not the whole component, but it is an important piece to that certainly from a budget perspective. But if most folks can get the crisis resolved in the community and in that time, that's great. We want to save our highest levels of care for individuals who truly need a hospital setting in order to manage and support what they're working through.
If I could ask you to move along so we actually get to the numbers.
We're ready.
It might take a few minutes.
Yep, that was the kindest way to say move it, move it. I like it. So we talked a little bit about workforce during this conversation, just to highlight a lot of the work that's been done around recruitment and retention. I'll let folks read through this on your own time. Those investments have worked. We also know that when you have let's say a bachelor's level individual who has a bachelor's degree in human services, that individual can choose a lot of different jobs that are very similar. And so right now we're looking at the functions of the positions that are in our system and making sure that we're delivering care in an efficient way and not a repetitive way where resources are sort of stepping on each other because they're really similar. And you'll see that as a theme when we get into our ups and downs.
If I may just say, this is helpful from a historical perspective, but I suspect it hasn't changed. It's still very challenging from a workforce perspective. So when you do your budget, will you have initiatives or suggestions to helping with that in fiscal year 26 and beyond? Matt, I remember the conversations all too well a year ago when, we had the traveling nurses issue and a big surprise at budget adjustment and,
Yeah.
it's challenging.
Absolutely. And it is challenging across all of healthcare. And so I'm sure you're hearing that with just about any testimony that's coming in here that's related to healthcare and other industries. You're right. We did do some great work with retention and recruitment from a travel nurse. There's still lots of work to do. There's still a 30-some% vacancy at the hospital, but we're seeing the results of that. And none of that wasn't going to be an overnight fix, but we are starting to see those vacancies come down. We've seen those vacancies start to come down at the community level as well. And so that gives us an opportunity to look at, well, how many positions do we have open? And how can we make sure we're shifting administrative work to administrative staff and licensed work being done by folks who are licensed and so on and so forth. And so that is what you're starting to see us evolve into as we see those retention and recruitment approaches take shape and positively impact. But that doesn't mean that there's still not large vacancy gaps within our system.
Question?
No, I was sighing at the enormity of this challenge, because it seems so persistent. And I'm just wondering how capacity is affected by vacancy rates. Like, how many more residential beds would we be able to open up? How many more if we had the staffing?
Right now, most of our residential bed closures are within our youth system. Your 24/7 facilities are the most challenging facilities to staff, particularly in the overnight hours. That position across healthcare, your 7 p.m. to 7 a.m. position is the most difficult to recruit. And that's where we see turning our focus into those with those residential programs and getting folks into those positions. It's not for everyone. Not everyone wants to work overnights. So that is something we are keeping our eye on. And I'll say that we want our community-based services to be the most stable because we know serving folks at our community allows for access to your highest levels of care when somebody needs them. Just like within healthcare in general, you want to be able to go into a med-surg bed if you're having a medical issue, but you don't want a bunch of people stuck in a med-surg bed who don't need to be there. It's the same within psychiatric and substance use treatment.
Thank you.
I'm going to turn it over to Shannon Thompson, our finance director.
Hi, good morning, everyone. So the first thing I wanted to talk about with the FY26 budget is that we are separating out the overall Department of Mental Health budget into two different appropriations. The first appropriation that we'll talk about is the DMH, which houses the central office staff, as well as operating expenses, and as well as all of the grants and contracts for providing the services. And then the second appropriation is for our facilities. So the Vermont Psychiatric Care Hospital, VPCH, you'll see throughout here, and the therapeutic residence, which is RVTR, River Valley Therapeutic Residence. So we've separated those out for transparency purposes, so you can see really what we're spending on those two facilities versus our central office and the rest of the system.
So it's safe to say that these first line items are related to the central office functions, and then in 315, we move into the facilities conversation.
Correct, yes, thank you,
Mhm.
yes. So this slide,
Yeah. we'll move this.
this slide here just kind of outlines our overall funding for the department. And as you can see, we're heavily funded with Medicaid or global commitment. You'll see probably throughout that we have Medicaid global commitment is going to be GC throughout the presentation. There are two different, there's Medicaid program dollars, which are also GC, and then there is the global commitment investments. So primarily it's Medicaid, and then we have some global commitment investments. We also have general fund, 31 million general fund.
If I could just ask a clarifying question. So when we look at the top line here, $334 million and change.
Yes.
If looking at your chart, the bulk of that's either, some of it's totally federal funding, and the bulk of the rest of it is global commitment with being to share with the federal.
Right. Yes,
Thank you.
you're welcome.
And I don't see any straight general fund dollars here in your chart.
It's the blue, it's the 9%. The general fund is 31,554,000.
Oh, okay. Yeah, okay. Thank you.
There's also a little bit of special funds, which is primarily Medicare and receipts that we receive from the hospital and the residents, the therapeutic community residents. And then we have a small portion of interdepartmental transfers. So we can talk about that a little bit later. So this just kind of outlines what our overall budget request is. Salary and fringe primarily, the initiatives that we've talked about. We have some PNMI pressures that you'll hear about a little bit later. And then we also have some budget reductions for the Howard Center Community Outreach Program, and then the embedded clinicians and pediatric offices. So we'll talk a little bit more about that as we go on. This chart here is just to show where we spend our money. So we have a large portion of our money that's spent on the adult services, what is right now being called CRT, Community Rehabilitation and Treatment. That is changing. We can talk about that a little bit later to SMI, adults with serious mental illness. And that's to do with our waiver. We also have a bucket of money for inpatient, $5.9 million there. Mobile crisis is about $9.3 million. In addition to that, we have other crisis services, which is 988, the alternatives TD, that are in our current budget of about $6.4 million. We have the psychiatric care hospital, which is about $34.5 million. The River Valley Therapeutic Residence, which is a little over $9 million. Children's Community Services, that is our case rates and peer services, also some federal grants. Then we also have the children's residential. Oh, that is actually a mistake there. That should be Success Beyond 6. So I need to change that label. My apologies. 72,250,000 is our Success Beyond 6 program. And then the children's residential is 10,160,000.
Yeah, what's that you have to go?
Could you just focus a little bit on Success Beyond 6? Has it shrunk from previous years? Has it grown? Is this pretty much a stable line item?
So this has been a $72 million for several years now. There was a point in time where it did fluctuate quite a bit. It went from about 60 million up to 72, the request. But really the actual spend has stayed in the $60 million range. This gives us authority to go up to $72 million.
Do the schools provide the match, the general fund?
They do.
How do the mechanics of that work?
So the Success Beyond Six program is funded with Medicaid dollars, right? So it's a portion of federal funds and a portion of general fund. The schools, the designated agency bills the department and they get the whole dollar from the department. And then they get the general fund portion directly from the school. And then
They're
they
billing
return
two
that to us.
places.
I'm sorry.
They're billing two sources? They're billing you and the school?
They're billing us for the Medicaid service, and then they're billing the school for the general fund portion, and that flows all the way through to us.
They transfer it to you?
Yes, they send checks.
So that's a big player.
Yes.
It's a big player in the
Yes.
portfolio, if you will.
Mhm.
Do you know, programmatically, if I'm a child on Success Beyond Six, are my parents also being served in some way? And how does the billing for that work? The school's probably not providing the match for that.
Do you want to take that or do you want me to?
Do you want to start?
Sure.
I'll fill in gaps.
Sure.
Okay.
So let's say a youth is getting services through the Success Beyond Six program. Parents, can choose to participate in treatment or not. Those parents are likely billed outside of that Success Beyond Six rate.
Yep.
Do we know if many parents choose to participate? Would we know?
Well, we have the clinician, the school-based clinician
Yeah.
case rate portion. Also.
Okay. It's probably not germane. I'm just curious if it's.
I mean, I think in general, parents want to participate in the services their kids are getting. Yeah, I would say my experience in working with youth is that parents want an active role. You have some parents that don't, but for the most part,
And some of the parents may not be Medicaid eligible,
yep, that's correct.
Mhm.
so that becomes a different issue.
They'd be either private or uninsured.
Yeah.
Thank you.
So we will start with the mental health central office appropriation, which is B314. And if you want, since we don't have a lot of time, I can kind of rush through the things that are like normal here, like the personal services increases. So the first line item here is actually, this is the transfer of the personal services amount from central office from the entire appropriation to the facilities appropriation under B315. So you're going to see the offset down below on the chart where it moves from central office down to facilities. That's
Where are we? Are we on this slide up here?
right.
And I think that the committee is looking at the Excel spreadsheet. We're looking through what's up here on our presentation. They should be pretty similar. So one of the first lines in 314 has personal services transferred to mental health facilities. That's what Shannon's talking about right now. And that's that 38 million.
Yeah, we don't have that. All we have is what's on the.
So we have AHS.
Yeah, oh, I'm sorry.
My apologies.
Yeah, no. We don't have.
We got it for the positive.
That we don't.
Yes.
Yeah.
You're under control.
Yeah, it looks like that's what
They're gonna say very similar information.
The other topic should follow exactly the line items in the spreadsheet.
They do.
They do.
This is 314.
Correct.
This is,
We just talked about the first line of moving the facility dollars. And that will be in 315. And so starting back up at 314 will be the central office functions.
I'm good. Did everybody find it 514 of 38 on that big spreadsheet? Thank you. All right. Okay.
Okay, so that is a transfer of 38,681,170. The next line item is the salary and fringe increases. There are multiple line items for those salary and wages, 483,275. The health insurance of 254,593. Retirement of 253,792.
Yeah, time out. Representative Loomis, do you want to go through each of the personnel related costs?
No, I just have one question about vacancy savings. It's because this is an up and down. We don't really know what that number is. It didn't increase from last year's. And what percentage, what is the vacancy savings? Is that, it depends, I know, overall, because you've got the central office and then you've got the facilities. So it's between 40 and 10, right?
So the vacancy savings is in the ballpark of 4% overall for the 4% of the overall personal services.
For central office.
Yes.
Okay, yeah. Thank you, that's all. And this is something that we can go over.
Yeah, if anyone has, I guess we're probably most interested. I mean, the salary changes because of pay act and other things they are what they are. If you're adding positions to increase that number, that they noted that, and I know Representative Lumley will dig in a little bit more detail when she meets with you.
Okay.
But so some of the kind of, you don't have any say in terms of what the retirement charges are that come from finance there. I don't think we need to scrutinize that. If it's
Okay.
yes.
Can you please explain Act 264 board stipends and parent representation
I would be
briefly?
Well, I would be happy to start that out. We have a $150,000 request for Act 264 board stipends and parent representation. That is for the stipends as well as trainings. Beginning in 22, the Department of Mental Health, we began paying for the payment representatives mandated under Act 264. So this was previously funded under our mental health block grant partially. And we've had grants with CHL. I'll let our commissioner talk a little bit more about that.
Actually, I think this one gets to go to deputy.
I guess I'll open it up if there's any questions, because Shannon did a nice job of highlighting how this is a requirement through Act 264. And it was being paid through block grant dollars. We needed to move it off block grant dollars. And so are there any questions that we could answer?
Well, it's not new, it's just we were paying them before. Thank you, that's helpful.
The next,
Representative over here.
I can wait till they're done the
Okay,
question.
thank you.
the next section, you're going to see $3 million, 306,308. That is to transfer the operating expenses from central office down to the facilities again. We also had some internal fund charges, which are your typical fee for space and vision charges and things like that. I'm assuming you want to brush over that a little bit. We have a technical correction here for between fund sources. This is zero gross, but it is under our operating expenses. We just, through our cost allocation program, we have discovered that the fund sources the money needs to move between fund sources. General fund, federal funds, global commitment, the amount we need in each bucket of money has changed over time. So that's all that is. We have some agency of digital services. Again, that's like an internal service fund increase. Then we have some transfers between the Department of Mental Health and the Department of Children and Family Services for our integrating family services IFS program. We had originally received funding in the 2015 timeframe, and we're moving those funds back to DCF to manage.
I saw that in the
Yes,
VAA.
Yes, yeah. Child Center. So there's 3 items under that. Does anybody have any questions, want to talk through?
I don't know if anybody has, sorry,
No, go ahead, go ahead.
Mr. Vice Chair.
I'm trying to respond to it here.
Oh, okay. I'm just looking at this and I'm wondering if you have built in any rate increases for the DAs and SSAs.
There are not.
Okay. Have they been, has that request been made?
I believe that the Vermont Care Partners, and those folks are all working together. But from a representative of the governor's budget, there's not a request.
Okay. All right. Is there anything in this grants area that is worth flagging? They're small numbers.
There's an amount, there are a couple of amounts for our CCBHC program. There's one transfer from Vermont Department of Health, their substance use department of $594,000 to support those 2 designated agencies who are becoming CCBHCs. And then there is an increase of global commitment for those 2 agencies because it will be an overall increased cost. However, because it's at an enhanced federal participation rate, there's actually a slight general fund savings for those. But those 2 items are to do with our CCBHs. Probably we should move down to PNMI. Oh,
Sorry, Representative, yeah.
Let's get.
Could you, how would you assess the fiscal stability of the designated agencies?
I would say the fiscal sustainability is varied across the system. And so that's something that we're looking at right now and have been. And if you think about rates in general, agencies have a lot of different lines of money coming into them. It's not only what they're billing under mental health. And so the Agency of Human Services is going through a process of looking at rates. It's very similar to legislation that's H13, I think is, there's legislation pending now, so that there's a more equitable process for rate setting.
Have you had any approach you for extraordinary financial relief in the last 18 months?
Yes,
How many?
2.
we could get that.
Yeah.
How do you respond to them? Are you able to respond?
They depend, it could go to various different places within the agency. I believe DIVA gets those depending on what the funding stream is that they're asking for, but we can get some additional
The
information
ones
for
that are
that.
stronger, if any, is there a pattern? Do you see any characteristics that would lead to that? They have more lines to bill, more services they're into, or is it something else?
Yeah, I think that's a really great question. And we do see variability across the state. I would say that no agency is making tons and tons of money. But I think as we move through our budget, one of the areas that I talked about earlier is looking at how to more efficiently assign staff for work. And so we want to make sure that the agencies are delivering those core services to their communities. And so we also know that agencies can't be everything to everyone. But part of our initiative with the CCBHC model and being a demonstration state and also engaging with enhanced mobile crisis provide opportunities to build down a higher federal match. So we want to make sure that we're delivering,
Direction.
those opportunities as much as possible.
Would it be fair, accurate of me to leave this meeting with the impression that they're struggling?
Not necessarily.
Some are and some aren't.
I would say some are and some aren't. I would,
Thank you.
you're welcome.
Mr. Chair?
I know that we're getting close to time. Is there any hot topic items you want us to look at?
No, I think we're okay. I had a meeting at 11. I backed that up to 11.
Mr. Vice Chair?
Yes, Representative LaRoche.
I'd like to ask if you were, do you have a good way of keeping track of the providers, and so that you can make sure that we're getting our money's worth and that the services being provided are the services that are needed in the field?
Yeah, so I'll start that off and
Yeah.
Deputy Sweet can chime in. I would say, yes, we collect data, service data across the agency, so we know who folks are serving, how many services there that are being delivered. Sam, do you want to add, Samantha, do you want to add anything?
We have a provider agreement that holds designated agencies accountable to measures that we want to collect to make sure that people are receiving the services and that they're better off because of these services. So we collect quite a bit of data around that based on the provider agreement that we have with agencies. We also have a designated review that we do up to every 4 years, depending on how they do on their review. Ones that agencies that do very well during that review can go every 4 years. Some are more frequent based on how that review goes, and that's for the designation. So we have a number of areas where we kind of monitor. And Shannon with her team oversees the budget of the agencies. So we have a number of places where we kind of keep our finger on the pulse.
I would say, as we look more into the CCBHCs, that CCBHC model is setting up our system to be comparable nationally, and setting us in line with more national standards as well. Making sure our communities are benefiting from the services that folks are receiving.
So are you happy or comfortable with where we stand now?
I think that we have a really great collaboration with our designated agency system. Do I think everyone is, and I think there's still work to do to meet our mission of making sure that folks are able to receive care when and where they want and need it. So to say that we've completed, can't say that, but I think we're moving in a really good direction. And I think part of that is the work that's been done around retention and recruitment. I think part of that is the willingness to look at a new payment model and a delivery of care through the CCBHC model. We've also started to really examine what's being delivered within our residential care system, as well as transforming services for what's historically been called the CRT population. So there is a tremendous amount of evolution happening within the system right now. And I believe we are all aligned with the goal of making sure our communities are receiving good care.
Thank you.
Sorry, I was multitasking, but are there things in the 315, 316 that you need to? 315 that you need to.
315, I think, is relatively straightforward. That's our facility numbers. I think I would like to spend some time back to our ups and downs related to our community outreach at Howard Center and the positions within two pediatric offices, because I think those will have the most questions and concerns.
Before we get there, Representative Lorky.
We've all been experiencing in the last week or so fairly healthy dose of chaos And when I look at the role that Medicaid funding plays, and then I hear this term using the Doge hammer to go after Medicaid and other funding sources that not every state depends on, I get concerned because I think there's somebody who holds that Doge hammer, an unelected person in our government that looks like he's ready to do damage. Are we looking at what we can do, even if temporarily we see interruptions in funding?
I would say, yes, we're always looking at those things, but there is a temperature of chaos happening. So I think two things. One, we want to make sure that our COOP plans are up to date. We work closely with AHS, with the governor's office. We're working closely with our federal associations. And so there is certainly an amount of anxiety that goes along with that because our communities rely on these services. And so I can't predict what happens at the federal level. I know that we're working to make sure that our communities are not impacted, or if there is an impact, it's as minimal as possible.
I'm glad to see the governor seems to have taken some actions to keep track of that, as well as our state treasurer did too. I guess we'll all have to do.
We're all in that, yeah. So I wanted to call out two line items that are here on the screen. One is the Howard Center Community Outreach. I'm going to let Deputy Sweet talk a little bit about this, but this looks and is a cut to that program as we work to incorporate enhanced mobile crisis into our community response. So I'll turn it over to Sam Sweet.
Thanks. So this speaks to one of the things that Commissioner Hawes talked about earlier, is looking at our services and making sure we're not having duplicate services. We only have, our staff are really finite, right? So we need to not have duplicate services in the community. What we see is Howard Center Community Outreach has staff that are within towns outside of Burlington. So this is not the Church Street outreach program. We're not touching that at all. This is the surrounding areas where there is a staff assigned to a certain town. That's all general fund. That cannot be billed to Medicaid at all. With Enhanced Mobile Crisis, a lot of effort, work, funding has gone into Enhanced Mobile Crisis to beef up, to increase the amount of services and staffing that can be provided to a county. And those are Medicaid billable services where we do receive the increased FMAP dollars. And that is a 2-person team. One is likely a peer. And so that is a much more robust system that's 24/7 in those communities, where before it was one person, potentially up to 40 hours per town. Now this is Enhanced Mobile Crisis that can do that outreach to that town as needed. So that's what you see here.
We also anticipate, there's a lot of phone call answering and a lot of phone call management support for community members, shifting those calls to 988 versus calling the local police department. We also want to gravitate our community members to do that 988 is answered. And most are resolved via the phone. And so from a community perspective, it is a culture shift. But from a staffing perspective, that staff member who is sitting at, say, a police department or the town, the city hall, that staff member could be somebody who's a part of And we want that person to be part of the enhanced mobile crisis response. So that when they respond to the community, they're able to, bill that service. And that if it's a phone call, the phone calls can go to the appropriate, resource, which is 988. This community outreach program was developed before, enhanced mobile crisis was implemented. And I think it's a natural shift in, what used to be non-billable to what's a billable, and a 24/7 support for communities.
If you think I need to leave, you're welcome to continue on, and Representative Blumley will chair the meeting. Thank you.
Thank you.
Thank you.
Any other questions about that program?
Yeah, thank you. There is a line here about federal authority, which was a BAA item.
Mm-hmm.
Um,
It's
Did
the
we
same thing,
put that
yeah.
back into the?
Go ahead.
BAA?
So that, I believe that is still in the BAA, and that is exactly the same line item. So we just need more federal spending authority within our appropriation. These are for programs that have actually already been approved. We just didn't have enough spending authority within our base budget, to be able to use the right, fund source.
Okay, so does that go into the BAA as a spending authority now as like a one-time, or is this be a C item, or how does that work?
So it will go into the BAA as basically one-time money, and then once that passes and gets approved, then we'll have access to those funds. And then in fiscal year 26, we're asking for the same.
So you will be asking for
It'll
this
be in our
going forward.
base, so then we don't have to write. Yep,
Thank you.
you're welcome.
The other line item I anticipate more questions around is related to the work being embedded clinicians at pediatric offices through Howard Center and Northeast Kingdom Human Services. So I'll turn that over to Deputy Sweet.
So this again, we're looking at utilizing staff in the best way possible and not having duplicate services. So this was funded, and KTES has not filled that position since 2020. So it's been vacant for the last 5 years. There is a position at Howard Center with Milton Family Practice. It is connected to the UVM Health Network. These are also services that help individuals, youth, connect to Medicaid program. And what we saw through the data is that majority of the kids that are seen in that practice are already connected to insurance. So we also saw the numbers to this program, it being pretty minimal for the amount of time that they're there. This is also funding that goes into First Call to connect individuals with Medicaid program as well. And what we saw is that a high percentage were already connected to insurance.
So for folks, First Call is what Howard Center names their crisis teams, for folks who aren't aware of that. They're the only agency that has received dollars to support supporting folks getting connected with Medicaid. And so we really want to make sure we're streamlining that across the system with existing resources.
And there's also an expectation that we want all our agencies to be able to connect people to insurance that they're eligible for. So that is an expectation that we have of every agency.
And not have a single designated person
Right.
doing that, yeah.
Correct.
Is there anything else? I mean, we haven't gone over 315.
We haven't facilities, and we certainly can. I think I was trying to be as mindful of time as possible, knowing that there might be more questions around those particular items. We also haven't touched on any PNMI increases that were a topic of conversation during BAA. We're happy to do that, whichever you would prefer.
Since not everybody would be familiar with that, why don't we start with that? And then we can take a look and see if anybody has any questions on 315.
Okay, so let's go back to the PNMI and 314.
Okay. So the PNMI, does everybody see that line item?
Yeah.
For $822,304.
So private non-medical institution.
Private non-medical institutions, yes. So the state of Vermont funds a network of treatment facilities for children and adolescents with emotional behavior and other challenges through these PNMI facilities. They're residential facilities. They provide treatment for children and families, which is designed to build on their strengths and return children to their homes and communities whenever possible and appropriate. We are seeing an increase in utilization in these facilities for the Department of Mental Health in particular, as well as increased costs. So I'll let Deputy Commissioner talk a little bit more about that.
Thanks. It is exactly like Shannon shared. What we are seeing is that more youth are needing residential at this time. And I'm sure you have heard in multiple places how coming out of the pandemic has been really hard, especially for our adolescent population. And that is exactly what we're seeing as well. And many are needing residential treatment for a period of time. So that's what this increase is an increase in utilization for the adolescent population to seek treatment within a residential facility.
In state or out of state?
Both.
Yeah.
Oh, we're seeing both, and this number reflects both in state and out of state.
Yes, does this include the educational schools? I mean, there's a variety of different, like, in an area there's SOAR,
Yeah.
that would be a PNMI.
So I'm gonna look at Shannon to answer
SOAR.
that. I don't think so.
SOAR
SOAR
is
is
not
a,
a PN, no, SOAR
not
is not a
a school.
PNMI. There's, and if
It's not
I
residential, but it
Right.
is.
Right, it's,
And the PNMI is a residential, so I believe that SOAR would be considered an alternative school. That's a collaboration, I believe, between the designated agency and the school system, but the
Yeah.
youth doesn't stay there.
No, but you're only talking about the residential ones.
Yes.
Correct.
So they are schools, residential treatment.
Yeah, residential is required to provide education
Yeah.
to the youth that are receiving services there. And some youth go to school and come back to the residential, and some it's all
Still there.
it's all
it's all
combined.
encompassing. These are funded with, there's also education dollars here, and not in our budget, but education pays for a component of these facilities. The next item with regard to PNMI is just the annual inflationary increase due to the new rules under rate setting. There's an inflationary factor for these facilities. And I believe you saw that in last year's as well.
And so I've just been informed that we are soon to lose our staff here. And so I think that maybe what I'd like to do is just on B315,
Mhm.
is there anything that you want to flag? I will be meeting, this is in my portfolio, we'll be meeting and I'll be going over all the line items. And then if we have further questions, you can come to me or we can discuss.
There are no unusual increases for the inpatient facilities. There's no request for additional funding for travel partners. There's just your traditional salary and fringe increases to pay act, your internal service fund increases. The only thing I will say here is that we are shifting funds from global commitment investment to general fund because of the institutions for mental disease changes and phase down. That's really all we have for the facilities.
And that's been an ongoing phase. So if that's worth talking more about, or we can answer questions outside this testimony.
I think just in the interest of the fact that we're dropping like flies, maybe that's something we'll talk about. I'm familiar with, this trend, but I also know that there may be others that have questions about it, and we can come back to it, the committee. Any other questions? Before we break?
I do have one quick one. Transfer from VDH for SUD services at the CCDHC, is net neutral. I would say corresponding change,
You should see
addition
one,
and
yes.
VDH.
Yes,
What's SUD?
substance use disorder.
That's not mine.
No.
I like it, yeah.
All right, if there are no other questions, thank you very much for joining us. And I guess the only announcement that I had to make is that we reconvene at 1 o'clock.